let's just dive right into this explainer. Today, we're tackling one of the most universally terrifying, yet honestly incredibly common physical sensations you can experience in your own body. We are going to completely decode the neurological machinery behind muscle fasciculations, which is just a fancy word for twitches, and we're going to focus specifically on the bulbar system.
So why does a tiny little muscle twitch cause so much absolute panic? Well, if you have ever felt a flicker, a quiver, or, that weird worm-like ripple in your tongue, you know exactly what I'm talking about. The immediate dread just sets in. See, the tongue is an incredibly unique muscle. Unlike your bicep or your calf, it is constantly active. It's always involved in speech, swallowing, even just subtle posture adjustments in your mouth. So when it starts twitching, it feels especially noticeable. And unfortunately, that feeling usually sends us straight to the absolute worst-case scenarios online.
And hey, we really have to validate that intense fear right out of the gate. You search your symptoms, and the internet immediately links tongue fasciculations to severe neurodegenerative diseases, most notably bulbar onset ALS. And honestly, the fear of this disease is exactly what fuels this whole anxiety loop. But to understand why your search results are terrifying you and why they are actually highly likely to be misleading you, we have to separate the mere symptom of a twitch from the actual reality of clinical failure.
Take a look at this. This shows what a true pathological presentation actually looks like. It's an image from a clinical case of a 47-year-old ALS patient. Notice the deep grooving there, the visible wasting of the muscle mass? I really want to highlight this point. Serious pathology involves visible atrophy, progressive weakness, slurred speech, and real difficulty swallowing. It is absolutely not just an isolated, temporary twitch in an otherwise perfectly normal-looking and normally functioning tongue.
Section 1. Upper versus lower motor neurons. Let's look at the nervous system's wiring.
Okay, so think of your nervous system in two distinct tiers. It's like a chain of command. You have the upper motor neurons, right? These act as the commanders. They originate way up in your cerebral cortex and send the signals for voluntary movement down into the brainstem or the spinal cord. Then you have the lower motor neurons. These are the soldiers on the ground. They take the direct order from the commanders and connect right to the muscle itself to actually execute the movement.
Understanding this hierarchy is literally everything, because where the damage occurs completely changes the clinical symptoms you're going to see. If you damage the upper motor neurons, our commanders, you essentially remove their calming, inhibitory control over the muscle. As a result, the muscles become stiff, super tight, and spastic, with hyperactive reflexes. But on the flip side, if you cut the lower motor neurons, the soldiers, the muscle gets completely disconnected from the brain. It just goes floppy, flaccid, and weak. Now, true pathological fasciculations are fundamentally a lower motor neuron phenomenon. When that lower soldier connection is cut or damaged, the muscle gets totally starved for signals. So in a desperate attempt to catch literally any electrical signal it can, the muscle creates extra acetylcholine receptors all across its surface. In medicine, this is called upregulation. The muscle becomes hypersensitive to any little mechanical stimuli, which results in those visible, involuntary worm-like twitches that we call fasciculations.
Section 2. Bulbar versus pseudobulbar palsy.
So there are some pretty stark clinical differences between these two pathways. Bulbar palsy is a classic lower motor neuron problem. It damages the cranial nerves directly, and that leads to a flaccid, weak tongue, completely absent gag reflexes, and those fasciculations we literally just talked about. Pseudobulbar palsy, on the other hand, is an upper motor neuron problem, often caused by something like bilateral strokes in the brain. Here, the tongue becomes spastic, the gag reflex goes completely hyperactive, and fascinatingly, it uniquely triggers what's called emotional lability. This means patients might experience uncontrollable pathological laughing or crying that is entirely disconnected from how they actually feel inside. Wild, right?
Section 3. Decoding diagnostic signs. Neurologists act a whole lot like electricians looking for a short circuit. They use a very specific clinical checklist to locate the exact point of failure in your wiring. For instance, when a neurologist examines your cranial nerve 12, that's the hypoglossal nerve, they're going to ask you to just stick your tongue straight out. Now, if there's a damaged lower motor neuron, the healthy side overpowers the weak side, and the tongue will actually deviate toward the side of the lesion. But if it's an upper motor neuron lesion, the tongue deviates away from the damaged side. And remember, they're always looking for an actual loss of muscle mass here, not just a random twitch. And they don't just look at your mouth either, they check the whole system. The Babinski sign is an absolute classic test for this. The doctor essentially strokes the bottom of your foot. Normally, your toes should curl downward, but if there's upper motor neuron damage, the big toe points up and the rest of the toes fan out. Now, here's a super surprising fact for you. It is perfectly normal to see a positive Babinski sign in babies under 1 year old. That's just because their upper motor neuron wiring hasn't fully myelinated, or, insulated yet.
Section 4. Function over fear. Okay, so now that we understand the dense neurology of true clinical failure and what doctors are actually looking for, let's pivot right back to that terrifying tongue twitch and arm you with some serious peace of mind. The vast majority of isolated twitches fall under something called benign fasciculation syndrome, or BFS. Basically, your nervous system is just running a little too hot. And this is heavily fueled by a hyper-vigilant anxiety loop. You feel a twitch, you freak out. You constantly check your tongue in the mirror with your phone flashlight, which, by the way, spikes your stress hormones, which then creates even more twitches. Throw in some sleep deprivation and a couple of extra cups of coffee, and you have got the perfect recipe for a completely harmless but very twitchy tongue.
So if you ever find yourself spiraling into health anxiety about this, stop staring in the mirror and test your actual function instead. Seriously, try this simple at-home check. Just ask yourself, can you read a paragraph out loud without slurring? Can you clearly articulate a tricky phrase like British Constitution? Can you drink a full glass of water without choking? Can you push your tongue firmly into your cheeks? If you can do all these things normally, it proves your anatomical machinery is still running perfectly smoothly, completely regardless of a little surface flicker.
So the absolute crucial takeaway here is what I call the golden rule of bulbar symptoms. Remember this. Clinical failure is fundamentally about losing function. It is about a progressive, real inability to speak, chew, and swallow. It is definitively not just about feeling a weird temporary sensation flickering on the surface of your tongue.
As we wrap up this explainer, I want to leave you with this thought. If your nervous system is essentially a vast electrical grid, a benign twitch is really just a tiny bit of harmless static on the line. As long as you can still speak and swallow, those wires are perfectly intact. So the next time your body acts up, ask yourself, are you listening to true failure of the wires, or are you just letting a little bit of harmless static drown out the beautifully complex, incredibly resilient machinery of your own biology?